Thank you for the introduction. The work I'm going to present today represents just one of the chapters in my thesis. So as George said, I'm looking at predicting 30-day mortality following percutaneous coronary intervention in England and Wales. So the motivating problem we have is that clinical risk prediction models can be useful for a variety of things. They can be used for decision support, for shared decision making. You can also use them to compare predictions with observed outcomes to evaluate performance of, say, clinicians, of hospitals, and then modify services accordingly. So in the UK, we have quite a lot of political pressure for accountability in clinical performance. There's a lot of calls for making league tables of surgeons or making mortality figures public. And sometimes it's argued that this helps patient choice, although it's not necessarily explained how a patient is supposed to choose on the basis of information that they might not understand. But it's certainly quite headline-grabbing stuff, and there's a huge importance to get this right. There have been some cases where just crude mortality rates have been released, and that's not necessarily very helpful. So, for example, if I give you two surgeons, surgeon A has a crude mortality rate of 5% and surgeon B has a crude mortality rate of 20%, and I asked you which one of these people would you rather do your operation, you're probably going to go for surgeon A. It's a bit of a no-brainer. But if I then tell you that surgeon A operates mostly on non-emergency cases in patients who are young and have no other health issues, and we would expect him or her to have an expected mortality rate of 2%, whereas surgeon B actually takes on a lot of difficult cases, emergency procedures, elderly patients, patients with comorbidities, and has an expected mortality rate of 35%, suddenly surgeon B is actually starting to look better. So the clinical context in which I'm looking at risk modelling is coronary revascularization. So this is a diagram of heart, and the bright red lines on the outside are the coronary arteries, and those are the arteries that supply the heart muscles with the blood that it needs to pump and do its job. And this is a cross-section through a coronary artery. And what we would like to see is a nice, big, empty white space here for the blood to flow through. And what we see instead is a kind of fatty deposit around the edge. And this can occur due to various lifestyle factors, like lack of exercise, certain dietary factors, smoking, or just the aging process. And what happens is when you get a blockage in a coronary artery, you get impaired blood flow to the heart, you're likely to develop problems like angina, and ultimately it might lead to a heart attack. So this is something that needs intervention. Now, one of there's several medical and clinical strategies we can use to deal with this. One of them is called percutaneous coronary intervention. And it's an invasive but non-surgical procedure in which a guide wire is passed up into the affected blood vessel. A balloon is inserted and inflated to push away the plaque, and then you can leave what's called a stent, which is like a metal mesh in place to keep the blood vessel open. So that's the particular procedure that I'm interested in. So the aims and objectives of this particular project were to enable the British Cardiovascular Intervention Society, or BCIS, to monitor the performance of all the UK cardiologists who undertake PCI. And the specific objectives were to produce a statistical model to predict 30-day mortality amongst patients using data from those in England and Wales, to perform validation of this model, and then to work with the National Institute of Clinical Outcomes Research to make sure that this model is implemented correctly. The data we used came from the British Cardiovascular Intervention Society itself. They collect data on all UK PCI cases. Over the last decade, there have been between 40 to 80,000 procedures per year. It's increased over time across about 110 centres. For this particular analysis, we excluded anyone aged under 18 or over 100, anyone who had missing outcome data, and patients who experienced out-of-hospital cardiac arrest, because we felt that the risk factors and the kind of patient pathway that patients who'd had a heart attack before, had a complete cardiac arrest before they reached hospital was so different that they needed to be treated as a separate group. The data were linked to the Office for National Statistics mortality data, but this was only available for England and Wales, and that's how we determined 30-day mortality. And this is just a schematic to show how the kind of data flows work. So all the different hospitals feed their data into NICOR, who collate it, carry out the linkage, and produce a data set that they then give to end users. This just shows the workflow that we had. We started off with quite a large candidate variable list. We developed an initial model, we evaluated its performance, and then based on kind of statistical assessment of a model and also clinical feedback on whether the risk factors were performing as they intuitively understood or whether there were anything that might be difficult to implement, we made further revisions. It was a very iterative process. and ultimately we came up with a final model. The statistical methodology was just logistic regression, using the binary outcome of being dead or alive at 30 days after the procedure. We split the data that we had available into a training set from 2007 to 2011 and a validation data set for 2012, so we could carry out temporal validation. If there were any missing categorical data, we assigned these to the baseline group, and where age was missing, we assigned that the median by gender, so the median age for men, the median age for women. We started off with a candidate list of variables, and they were selected mostly on the basis of clinical consensus, but also with regard to data quality concerns. So there were some variables we wanted to look at, but the data just weren't good enough at this time. We used model reduction using backward selection on the basis of the Okaki information criteria. We didn't use any kind of p-value based model selection approaches on the basis that this is a very large data set, and there can be some problems with some of these approaches in large data sets. And we assessed the performance on the basis of the model's discriminative ability as measured by the area under the ROC curve and the calibration of the model using plots. So here is the model. We have a number of variables. Mean-centered age at procedure was the only continuous variable. We also had gender, diabetes, previous myocardial infarction, a history of renal disease, a history of a cerebrovascular event or stroke or similar conditions. We combined both the clinical indication and the urgency of the procedure into a new variable because there's quite a lot of collinearity between those two variables, and it just made sense to kind of acknowledge the relationship between those two. We also looked at left main stem stenosis and cardiogenic shock, which is actually the largest categorical predictor in this model. We also included, oh, that's gone wonky. The bottom three are actually interaction terms, and we included these because the initial models we developed, the calibration was tending to over-predict in the highest risk patients. So we introduced some interaction terms to kind of correct for this. So if you happen to have, an urgent indication and you have cardiogenic shock, your risk is not necessarily the same as adding those two things together. So we needed to kind of correct for that. Here is the model performance on the training data. So from 2007 to 2011, there were about 350,000 patients, of whom 1.68% died within 30 days of procedure. On the left, we have a calibration plot. So the straight line would indicate perfect calibration. On the x-axis, we have the predicted risk, and on the y-axis, we have the observed risk. So you can see that the points are kind of scattering fairly close to the line. So this indicates a fairly good calibration. The area under the ROC curve, the discrimination, was 0.85, and this could be better, but equally it's well within the range of normal values for this clinical domain. So typically models in this area will have an AUC of around 0.7 to 0.9. In the validation data, we had 80,000 patients from 2012, of whom 1.99% died within 30 days of procedure. There is a slightly higher mortality rate here, but that ties in with a change in clinical practice over the last few years and the degree of severity of cases seen. And in this case, you can see that there's a bit more scatter in the calibration plot. The dots are a bit further from the line, but you can still see that there is an overall trend towards good calibration. And we maintained a good discrimination with an area under the curve of 0.86. So just to discuss a few strengths of this model, the previous model that's being used in UK audit up until recently was published 8 years ago, based on data from 2001, so it's just out of date. It needed replacing, so something more contemporary was likely to be an improvement. Specifically, this model incorporates data that reflect, as I said, there's been changes to clinical practice. So now, instead of just using PCI as a kind of prophylactic intervention in anticipation of somebody maybe having a heart attack, it's actually also used as a treatment when someone has just had a heart attack within a few hours of that occurring, as a way of dealing with a blockage. So these cases are obviously more difficult, more likely to have mortality associated with them, which explains why mortality has increased over the last few years. We focused on a hard endpoint which is believed to be more reliably recorded than some other outcomes. So the previous model looked at a variety of cardiovascular and cerebrovascular outcomes, some of which were really well recorded by hospitals, but some of which weren't. So we knew that if we looked at 30-day mortality as measured in the ONS, we could be more certain that our outcomes were actually true. And overall, the model has good discrimination and calibration. And I've not shown it here, but we also looked at two clinically important subgroups, namely the primary PCI cases and the non-primary PCI cases, and we found that the model performed well in both of those. So it wasn't just being kind of swayed by one or the other. There are some limitations, so we've not yet validated it on external data sets. One of the strengths is that I've managed to use all the data in England and Wales, but having used all the data in England and Wales, I've got no more. So we do need to look at other populations to maybe get an external validation of the model. That being the case, because it's only based on data from England and Wales, yet it's going to be applied to clinicians in Scotland and Northern Ireland. There are slightly different mortality patterns there, there are slightly different risk factors, so it might be the case that the model doesn't perform as consistently in those populations as it does in England and Wales. So that's something that needs to be taken into consideration during the implementation. We had too much missing data in some variables of interest, which meant we excluded them from consideration. So, for example, left ventricular ejection fraction is likely to have been a very good predictor, but it was missing in 50% of cases overall, in 75% of emergency cases. We'd have also liked to look at a better measure of renal function. So we'd have liked to look at eGFR. It's now being collected, but it hasn't been very much in the past, so we were a bit reliant on kind of creatinine thresholds as a proxy measure. The chosen outcome is only one measure of clinical performance, and patients might be more interested in other outcomes. So the 30-day mortality rate is quite low, but as a patient, you're probably more concerned with, when can I go back to work? What's my quality of life going to be like in a year's time? Am I still going to be alive in 5 years' time? So the model is just focused very much on a clinical measure. So finally, I'd just like to say thank you to the British Cardiovascular Intervention Society for providing me with the data, and to my collaborators and advisors, and to NIHR for funding my PhD. Thank you. Good question. I think we need to move away from the notion that once you make a good model, it's a good model forever, because there are so many things that change dynamically, whether it's improvements in performance or changes in patient populations demographically or in terms of clinical indications. And I think that models should probably, if they're going to be used in something as important as a national audit project, you should probably kind of at least examine them, if not recalibrate them year on year, maybe with a rolling window of data. So I only used data back as far as 2007 because that was all we had. But I would say that if the model was going to be recalibrated in a year or two, not to bother using that data, to maybe use just a 5-year moving window of data. So I think it needs to be part of the kind of the modelling process to bear in mind that these things do have an expiry date.
Do you think it's possible to automate that process? So this is also like a medical data. You're saying,
yes.
Next year we need new PhD students to recalibrate the model.
Basically, yes.
Yeah.
I think, I'm not a computer scientist, but I don't see why you couldn't write an algorithm that compared the new data that came in, automatically fitted it to use the old model to fit it, examine things like calibration plots or other measures, and kind of triggered some kind of alert that said, this is now approaching a point at which you might want to intervene. It's technically feasible. Whether the infrastructure and the willingness is there is another matter, because I think it can be very slow turning the ship around with some of these models. So the Euroscore model in cardiac surgery was used for a good 5 or 6 years after people first started saying, this isn't very well calibrated anymore. And it took quite a long time for people to actually adopt a new, or develop a new model and for that to be adopted. So I think it's partly a technological challenge, but also partly a kind of culture shift challenge as well. Yes.
So this is data that's all collected in hospital at the time, recorded by cardiologists when patients are in after they've had procedure. So I'm just wondering about recall bias, for example, in prior MI, because you've got no GP data or any other data feeding into
Yeah,
analysis.
actually it's not quite collected as as rigorously as you described. So this is almost like a derived secondary database based on patient records. So it's not a case that patient comes in and as they're being assessed, everything's going straight into the BSIS record. What happens is at a later date, and that might be that afternoon, or it might be at the end of the month, or at the end of the audit year, someone will transfer information from the patient record into the database. So there's obviously problems of potential just transcribing errors. I know some hospitals, for example, with Ensure do actually employ internal validation people to actually make sure that the data quality is good, but that's not universal. So you do, as you say, have issues with recall bias. It's based on, you know, asking the patient, did you have a heart attack before? Or if they've maybe had a heart attack before at that hospital and you've got a record, great. But as you say, there could well be issues with that. And we were quite limited in what comorbidities and what medical history we could look at, because there's only certain things that are recorded. And then there are other things like, say, smoking, which would probably, you know, have a bearing on your mortality risk, but the way that the data are collected just mean you can't even really consider them for interest. So there are, you know, limitations in the pool of variables that we had available to us.
Kate, you've given us a very nice, clear, parsimonious epidemiological story about the development of this model. Bottom line for this discussion and questioning, case mix adjustment is hard, and models drift in calibration. Your BSIS group won't be the only ones saying, wish we could have included left ventricular ejection fraction, or why do we have to use renal function as a binary variable? Clearly, there are things around the model that were talked about while putting the model carefully together. How do you think we should capture those things around the model? Which kind of organisation would be nice? Another body? Do you think we should call the larder a case mix adjustment?
On the first point, I think it is useful to properly document these things and maybe make that available. For example, we had conversations about peripheral vascular disease, and from my point of view as an analyst, it seemed perfectly good to have it in the model. From their point of view, there was an argument that it's something that's too easy to gain. It's too easy to sort of claim that someone's got peripheral vascular disease when maybe they have, but maybe they just get achy legs sometimes and you're not really sure. So there were lots of conversations around those kind of things, and that did actually shape what went into the model. In terms of who should kind of hold these things, I think it's difficult because you have, say, an organisation like BSIS or SCTS, they have ownership of the data and they have ownership of the modelling process and then the audit process. So if you said, let's all send it to a kind of centralised organisation like NICE, there would be possible benefits in more consistency, saying how models are recalibrated, how they're implemented. But I think, again, it's another thing where maybe you need a bit of a culture shift before something like that could happen. And I think there could be, you know, quite a few things that would need ironing out along the way. So I'm not sure whether that would be the best move, because perhaps it is better to keep these models seated within the respected kind of clinical specialist groups.
Do you think those specialist groups learn from one another at the moment?
Maybe to some extent, now that they've introduced the reporting on these 10 kind of surgical procedures, there's perhaps going to be more people looking at how other people are doing things. I think the other thing that I didn't mention was that where we've got some variables where there's not very good data quality, there were conversations around, okay, well, let's either put in the model that variable to incentivise better data quality collection in the future, or make a statement that, okay, we couldn't include EGFR right now, but we want to include it in the future, therefore we're now making this a mandatory field where it was optional before. And so you can kind of, if you keep the control of these things within particular organisations, maybe they can have more influence over their respected kind of clinical populations than if you centralised it. I don't know what the best thing would be, but I can see pros and cons of either.
In terms of validation, you mentioned that there's a inherent variability over time and probably location. So do you think a model that is based on largely a complete data set, or at least a data set as complete as possible to get, is possible to be validated?
Yes, you can still look at whether your assumptions from one model holds true in another population. So if we took a data set from, say, Sweden or something, and we validated our model and it still performed well, well, that actually indicates that we've kind of hit upon a few sort of maybe widespread relationships between things. It's not just limited to the quirks of the NHS and the particular English and Welsh populations. Equally, if you did validate it in a Swedish population and found that it didn't perform as well, that doesn't necessarily mean it's not good for use in England and Wales. So I think it very much depends on what your end use is, and I'm very keen that models should be developed with a particular end use in mind. So I don't like the idea of this model being used for clinical decision support, because I think the degree of uncertainty around the estimates is perfectly fine when you're applying it to someone's entire caseload. But if you go then to an individual patient and say, oh, we've estimated your risk as 20% plus or minus 10%, and then ask them to make a decision as to whether they want an intervention, that's not really appropriate. So if you've decided that a model is just going to be limited to use in one population, I think then, you need to emphasize more things like temporal validation rather than external validation, perhaps.
Thank you very much.